Welcome to this board review on prenatal care management. This video is brought to you by Roadmap to Residency. Prenatal care is one of the highest yield topics on your exam, and the questions almost never ask you to simply recall a fact. Instead, they hand you a pregnant patient at a specific point in her pregnancy and ask what you should do next. Our goal today is not to reteach all of obstetrics. It is to show you how these question stems are built and how to attack them. You will get the most out of this video if you are also working through your question bank and a trusted review resource alongside it, because these patterns become automatic only by doing many practice questions. Let us get started. Here is what we are going to cover today. First, we will learn how to read a prenatal vignette the way a working physician does, by finding the gestational age and the visit type before anything else, because those two details decide the answer. Second, we will move through the 4 big prenatal themes that the exam tests again and again, which are the initial prenatal visit, the routine testing schedule across the 3 trimesters, identifying the high-risk pregnancy, and managing common pregnancy complaints. Along the way, we will work through several practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you already have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to read every prenatal vignette the way a working physician does. Start with the last line of the question. That sentence tells you what is actually being asked, whether it is the next best step, the most appropriate test for this week, or the best treatment for a complaint. Once you know the question, go back and read the stem with that goal in mind, and you will stop drowning in detail. Then anchor on the gestational age. In prenatal care, the number of weeks of pregnancy is the single most powerful clue in the entire stem. A test that is correct in the first trimester is wrong in the third, and a symptom that is harmless early can be a danger sign late. Get in the habit of circling the gestational age before you read anything else, because more often than not, it decides the answer. Our second strategy is to know exactly what the initial prenatal visit includes, because the exam tests it constantly. First, know the first visit panel cold. It includes the blood type and antibody screen, a complete blood count, infection testing such as human immunodeficiency virus, syphilis, hepatitis B, and rubella immunity, a urine culture, and cervical cancer screening if it is due. When a stem describes a brand new prenatal patient, the answer is very often the one piece of this standard panel that has not been done yet. Second, remember that the first visit is just as much about counseling and prevention. Folic acid should already be on board, ideally started before conception, to reduce the risk of neural tube defects. Look for answers about confirming the due date with an ultrasound, reviewing which medications are safe, and offering early screening when there are risk factors. When you are stuck between 2 reasonable choices, the better answer usually protects both the mother and the developing baby. Our third area is the routine testing schedule, organized by trimester, because the exam loves to ask which test belongs at which point in pregnancy. In the first trimester, you establish the pregnancy and screen. That means the standard first visit panel, an ultrasound to confirm the dates, and optional early aneuploidy screening that combines a blood test with a neutral translucency measurement. Cell-free fetal deoxyribonucleic acid screening can also be offered here. In the second trimester, think anatomy and sugar. The detailed anatomy ultrasound is performed around the start of the second half of pregnancy. The maternal serum quadruple screen is offered in the same window, and glucose screening for gestational diabetes comes near the end of the second trimester. In the third trimester, you protect the delivery. That includes a repeat blood count, a swab for Group B Strep late in pregnancy, and giving Rogum to a mother who is rhesus negative. The single most useful move is to anchor on the gestational age, because each of these tests is tightly tied to a specific window, and that window is what the question is really testing. Let us work through our first practice question, and this one is built to test the initial prenatal visit. A 26-year-old woman comes to the clinic for her first prenatal visit at 9 weeks of pregnancy. She feels well, takes no medications, and has no chronic conditions. She is not sure whether she has ever been immune to rubella. Her blood pressure and the rest of her exam are normal. The question asks for the most appropriate next step. Before you choose, notice 2 things. This is a first visit, and the gestational age is early, only 9 weeks. Those 2 facts should point you toward the standard first visit workup, rather than anything that belongs later in pregnancy. Read the 4 options carefully and lock in your answer. Then we will walk through the reasoning together on the next slide. Let us break this down step by step. First, spot the pattern. We have a healthy woman at her very first prenatal visit, early in the first trimester at 9 weeks, and the STEM makes a point of telling us that her rubella immunity is unknown. That is a quiet hint that the standard panel, which checks rubella immunity, has not been done yet. Next, apply the rule. At a first prenatal visit, the correct action is to order the standard first visit panel, which includes the blood type and antibody screen, a complete blood count, infection testing, a urine culture, and rubella immunity. Choice A is the only option that fits this stage of pregnancy, so the answer is the standard first visit prenatal laboratory panel. Now eliminate the wrong answers. The rubella vaccine is a live vaccine and is not given during pregnancy, so choice B is actually unsafe here, and that makes it a classic trap. Glucose screening belongs near the end of the second trimester, so choice C is far too early. The detailed anatomy ultrasound is scheduled around the midpoint of pregnancy, so choice D is premature as well. Notice how simply anchoring on the gestational age and recognizing this as a first visit pointed you straight to the answer. Here is our second practice question, and this one is all about the timing of routine testing. A 31-year-old woman at 26 weeks of pregnancy comes in for a routine visit. Her pregnancy has been uncomplicated. Her first trimester screening and her mid-pregnancy anatomy ultrasound were both normal, and she has no symptoms today. The question asks which routine test is appropriate at this visit. This is the kind of question where anchoring on the gestational age does all of the work for you. 26 weeks places her right at the end of the second trimester, which is exactly the window for one specific routine test. Before you choose, ask yourself which test belongs at this point in pregnancy and which tests have already passed or have not yet arrived. Lock in your answer, and we will reason through it on the next slide. Let us work through this answer. First, anchor on the week. The patient is at 26 weeks, which places her right at the end of the second trimester, and that is the standard window for screening every pregnant patient for gestational diabetes with the glucose screening test. Since her pregnancy has been completely normal so far, this routine screen is exactly what is due at this visit. Now let us see why the other options are wrong, and notice that each one is a real test simply placed in the wrong week. The swab for Group B Streptococcus is collected late in the third trimester, so it is too early here. The first trimester aneuploidy screen has already passed and cannot be done now. A repeat anatomy ultrasound is not a routine test when the first one was normal. This is the heart of routine prenatal testing questions. The exam fills the choices with legitimate tests and asks you to pick the one that matches the gestational age in front of you. The correct answer is the glucose screening test for gestational diabetes. Now let us talk about identifying the high-risk pregnancy, which is one of the most testable skills in this whole topic. First, flag the risk factors early. The exam almost always plants the high-risk clue right in the opening line of the STEM, so train your eye to catch it. The classic ones are older maternal age, high blood pressure, diabetes that existed before the pregnancy, obesity, a prior cesarean delivery, a prior preterm birth, twins, and tobacco or substance use. The moment you spot one of these, expect the question to ask you for closer surveillance or for a workup that happens earlier and is more intensive than usual. Second, let the risk raise the intensity of your answer. Once a patient is high risk, the correct choice tends to shift toward more monitoring. High blood pressure should make you watch for preeclampsia, diabetes before pregnancy should make you test glucose early rather than waiting, and several risk factors call for added growth ultrasounds or fetal testing later in pregnancy. Here is the key test-taking insight. The calm, reassuring, do-nothing answer that would be perfectly correct for a low-risk patient becomes the trap answer the instant a risk factor appears. So always ask whether this patient is low-risk or high-risk before you decide how aggressive to be. Here is our third practice question, and it rewards your ability to spot the high-risk pregnancy. A 38-year-old woman comes for her first prenatal visit at 8 weeks of pregnancy. She has had type 2 diabetes for several years with only fair control, and she also has high blood pressure. She feels well today, and aside from a mildly elevated blood pressure, her exam is normal. The question asks for the most appropriate next step beyond the standard first visit panel. The very first thing to do is decide whether this patient is low risk or high risk. Look at the opening line: older maternal age, diabetes that existed before pregnancy, and chronic high blood pressure are 3 classic high-risk flags stacked into one STEM. That should immediately tell you the answer will lean toward earlier and closer monitoring, not toward reassurance. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, look at the risk stack. This single patient carries several high-risk features at once. She is of older maternal age, she has diabetes that predates the pregnancy, and she has chronic high blood pressure. Whenever you see risk factors piling up like this in the opening line, the exam is signaling that the answer leans toward earlier and more intensive care. Diabetes that existed before pregnancy specifically calls for early glucose testing rather than waiting until the usual late second trimester window, and her chronic conditions deserve a baseline assessment right now. That makes choice A, early glucose testing and a baseline assessment, the correct next step. Now the key distinction between the wrong choices. Choice B, waiting until the end of the second trimester to screen, ignores the rule that pre-existing diabetes needs early testing. Choice C, reassuring her that she is low risk, is the central trap of the question, because her risk factors make that statement simply false, and this is the reassurance answer that would have been correct only for a low-risk patient. Choice D, stopping all of her medications, is unsafe and abandons treatment she needs. The correct answer is early glucose testing and a baseline assessment for her chronic conditions. Our last theme is common pregnancy complaints, and the test-taking pearl here is to treat them as benign until proven otherwise. First, know what normal looks like and be ready to reassure and treat simply. Nausea early in pregnancy, mild swelling of the legs, constipation, low back pain, and heartburn are all common and usually harmless. When the vignette describes one of these in a stable patient whose vital signs are normal, the correct answer is reassurance plus a simple, safe first measure, such as a dietary change or a pregnancy-safe remedy, rather than ordering imaging or admitting the patient. The expensive workup is almost always the trap. Second, train yourself to catch the danger, because the exam loves to hide a dangerous look-alike inside an ordinary-sounding complaint. A severe headache together with high blood pressure should make you think of preeclampsia. A severe one-sided headache or a change in vision is not just a normal headache of pregnancy. Heavy vaginal bleeding, severe abdominal pain, or any complaint paired with abnormal vital signs is never simple discomfort. The entire skill in these questions is separating the benign version of a complaint from the red flag version, and the clues that tell them apart are always sitting right there in the vital signs and the severity described in the stem. That wraps up our review of prenatal care management. Remember the core ideas we covered today. First, read every prenatal vignette by anchoring on the gestational age, because the week of pregnancy almost always decides the answer. Second, know the initial visit panel and the routine testing schedule across the 3 trimesters cold, so you can match the right test to the right week. Third, learn to spot the high-risk pregnancy in the opening line, and let those risk factors raise the intensity of your answer. And fourth, treat common complaints as benign until proven otherwise, reassuring and treating simply while staying alert for the red flag version hidden in the vital signs. The best way to lock all of this in is to drill questions in your question bank under timed conditions and read every explanation, even on the ones you got right, alongside a trusted obstetrics review resource. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.